Great. And welcome to episode 221 of the 988 Crisis Jam. My name is Megan Haupt. I'm Chief of Staff with the National Association of State Mental Health Program Directors, otherwise known as NASHPID. Today is, as I said, episode 221. It's a day in the life of crisis care, part 2, someone to respond. So it's really on mobile crisis, and we're thrilled to have Elizabeth Jimenez, Kaitlyn Ervin, and Megan Gleason. Thank you. And just some housekeeping items before we start to jump in. The main thing is to stay on mute unless you're a presenter and you're about to present. But there's also the opportunity to select speaker view instead of gallery, so you can see the speaker and the PowerPoint side by side. We encourage you to join in with the chat, share your thoughts and your questions. And when we have a trivia showdown, which will be coming, put your answer in the poll versus the chat so that we get to see kind of what everybody thinks. It is anonymous, so don't feel embarrassed if you feel like you don't know the answer. Want to emphasize the new ASL feature, American Sign Language feature. One of the beautiful things about this 988 Crisis Jam is that it is accessible to so many, including people who are deaf and use ASL. So to get that, you can see the little 3 dots where it says more, and you can then bring the interpreters directly to your screen by choosing that option. Great. And the Crisis Jam, gosh, we've had 221 episodes since 2020, and we've had 558 unique speakers, and the speakers of from today, just this episode, will add even more. So if you've got a hot topic, an idea, please let us know. We'd love to be able to add you to this list of just incredible presenters and participants. Our community, though, is thousands. So we love that. We love that this community is growing, that it's done by YouTube, that it's done by Zoom. We just keep reimagining it and growing in this way. So to get to past episodes, you can go to talk.crisisnow.com. So there's all kinds of little features in there, some of the newsletter pieces. But to register, you see that register for the Crisis Jam, you do need to register, and you get a personal link. So don't share that personal link with anybody. That's very specific to you. And, there are all those background materials and so forth. The neat thing is, something that's newer is the ability to have our Crisis Jam live stream through YouTube. So we love that. One of the things that's more difficult with YouTube, we can't do more of a chat. So we encourage people to be on Zoom, so there's more interaction through the chat and so forth. But if you need to live stream because of an issue with Zoom, it is available. So great. And the neatest thing about the Crisis Jam and the ways that it's grown, we have different kinds, different ways of learning. So we've got the feature presentations, we've got debates, we've got live on location, we've got day in the life. So all of those things are different ways. And of course, available on YouTube. Like and subscribe. I'm seeing this little pop-up there. So very cool. And so the live and on location, we just recently had one in Columbus, Ohio, and before that at the Huntsman Crisis Center in Utah. So last week was episode 220, live and on location, Franklin County Crisis Care Center in Ohio. It was great, just a fantastic, and the contrast between the Huntsman live and on location and the Franklin County Crisis Care Center. It's so neat to see the differences across centers and communities. Wonderful. Next slide. Great. And so our debates really have ramped up with season 5. So let's go into what those debates are. Our next debate is coming June 18th. It's on crisis facilities should require parents to stay during a crisis episode. So Gwenda Summers is going to take the affirmative with that, and Dr. Vernon Barksdale is going to take, I guess we could say the negative, but maybe a different perspective on that. And Dr. Vernon Barksdale, it just comes from one of the well-renowned centers for children. So really excited for that. And then there'll be a debate coming July 16th between David Covington and Dr. Jessica Pollard. Now, I shouldn't say it's really between them. What I really should say is the subject. So coordinating follow-up care and crisis services requires high-tech software solutions. So David Covington will take the affirmative, and Dr. Jessica Pollard, who is with NASHBID, will actually take the negative on that. So that'll be a very interesting debate. And then coming August 27th, the next debate would be states should prioritize building capacity in the 3 core crisis services. Now, this is very interesting because Paul Galdis, the 3 core crisis services of 988 mobile crisis and crisis stabilization. And then, but Dr. Joe Parks is actually going to take a different perspective, that there's more like a roadmap, that there are many steps, and he'll be highlighting some of that. So that's episode 232, August 27th. And season 6, coming September 17th, 2025, we are calling it Crisis Jam Unplugged. Now, the Crisis Jam, because we're looking at more of a continuum of services, it will be called the Crisis Jam. And the unplugged piece, I don't even know it yet. It's more to come. So pay attention for that, September 17th, 2025. And so there'll be debates. This is kind of using Larry Bird and Magic Johnson to kind of describe that kind of iconic debate, Crisis Jam Unplugged for season 6. And so let's get to kind of more the news on things. So NHS is to open network of mental health A&E across England. A&E is assessment and evaluation across England. And so this is some of the latest crisis news. NHS is in the UK, and it's really looking at doing this. They have very similar issues that we do in terms of the ER boarding. So this is an approach that they are giving a try. All right. And this is very interesting because in California, there was an instance where they called for urgent help with a mentally ill loved one, but the California police had refused to respond. And part of that challenge is law enforcement. If there is not a strong continuum of care or crisis services, police have a very difficult experience in terms of being able to respond. It's not necessarily a treatment response. And sometimes, they're at risk for liability for responding in ways that they're trained in, but not trained in crisis. So it's so much better to have a crisis continuum, 988, mobile crisis stabilization, so that law enforcement can just drop off and they can get back to their jobs. So that's that emphasis there. And let's get to the Crisis Jam Showdown. So this is really interesting. So I'll read this. Following the tragic death of a Washington state social worker in 2006, safety summits were convened and guidance was issued to protect community mental health workers in the field. So which of the following is not one of the recommended best practices? A, 2-person teams. B, 24-hour access to justice history. C, partner with police if needed. or meet in hospitals, hospital EDs or secure setting. So which of the following is not one of the recommended best practices? Go ahead and put your answer in the Crisis Jam Showdown poll there. And all right, let's see what people did. Did you know what really happened here? Okay, so it looks like it is split between 24-hour access to justice history or meet in hospital EDs. Very interesting. And the two-person teams, it looks like everybody would think that that happened and partner with police if needed. Everybody thinks that would happen. But the other two, it's more of a question. Let's take a look. Yeah, meet and hospital EDs. So this, if you were in the pre-show, we showed a video of where mobile crisis response goes to where the person is. That's like the iconic piece of mobile crisis. So meeting and hospital EDs is the one that it did not come recommended. So yeah, that's what this whole jam is about mobile crisis today. So we'll learn more. Thank you. And Wednesday, September 15th, 2021 was back when they did kind of a day in the life. It was the first day in the life and they called it Go. And it was also on mobile crisis. So it's just titled Go. How cool is that? 4 years ago almost. And so now we'll move to a day in the life of crisis care part 2, someone to respond. I'm going to turn this over to Megan Gleason, um, who will lead this discussion. Thank you so much, Megan.
Thanks, Megan. I'd like to again introduce two of my other panelists here with me today, Elizabeth and Kaitlyn. And the really cool thing about today is that we are going to be talking about kind of the reality of mobile crisis and from three different perspectives, three different programs in three different states. And I think what's really cool is that we all have different experiences. Our teams function slightly different, but there's also a lot of similarities that we're going to be able to talk about. So, welcome, Elizabeth and Kaitlyn.
Thank you, Megan.
So, I wanted to just start by asking, could you guys just introduce a little bit about who you are and where you're from? What state?
Sure, I can go first. Hi, Kaitlyn Ervin, Director of Crisis Continuum at Aspire, Indiana. We service Central Indiana, so some of the key counties around Indianapolis area.
And your program's been live for about a year?
So our mobile crisis has been live a little over a year. The 24/7 aspect of it has only been a few months. We also have our crisis call center, and that has been close to 40 years that's been running.
Wonderful. Elizabeth?
Hey, everyone. So my name is Elizabeth Jimenez. I'm one of the crisis manager with Frontera Impact, and I'm out of Tempe, Arizona. We do have several offices in the outskirts of Phoenix that helps us with response time. The team that's closest to the call will be typically the call that responds. And I actually started my career here with Frontera as a therapist on a crisis mobile team. So this is always exciting for me to talk about.
Wonderful. Well, I did want to start with you after I introduce myself briefly. My name is Megan Gleason, and I am part of Behavioral Health Inc.'s Mobile Crisis Program. I've been doing mobile crisis for almost 14 years now. And just like my partners here, love this work and really strongly believe the impact that mobile crisis makes. So excited to talk about it. I wanted to start today off by just talking a little bit about where and how teams are dispatched. So, are they dispatched through 988? Are they dispatched through a different process? And I think, Elizabeth, let's just start with you and kind of talk about where you guys get dispatched from.
Mhm. So anyone can call our 988 line and they can get a team dispatched to them, but we also have an Arizona crisis line if someone wants to call directly. And then both of those lines, they'll get dispatcher, they'll get kind of a screening, and then from there, they'll get the dispatched out to one of our teams.
Okay. Kaitlyn, what about you guys?
Yeah, for us, we have our crisis line that's utilized. So 988 can call us and dispatch us. We have close relationships with and partnerships with our community partners and first responders. So they often will call us and request mobile crisis to co respond with them. And then also, anyone can call our crisis line. And so through that, assessing and we could dispatch out if they are wanting us to meet them in person.
Wonderful. In BHL in Georgia, we are dispatched through the Georgia Crisis and Access Line or 988 as well. And that is primarily how we get our dispatches because it just comes through our continuum of care to our teams across the state. Elizabeth, do you want to talk a little bit about how your team prepares to go out and on scene engagement?
Mhm. Absolutely. So once the call comes in, the mobile team receives it via app. So there's an app on their phone, and they get like a small snip of, who's a client, what's happening, what's the reason for us being dispatched. The team also has a laptop that they have. They're able to log in there, and they're able to also get additional fields. That way they have, the most information on hand. They're always ready for the dispatch because we never know when a dispatch is going to come in. So our motto is out the door in like 4 minutes. So we have all of our equipment with us, which is the laptop. Both team members have a phone with them as well. And then we head out the door. There is a shared company van that they use to go out to the call, and we're mobile crisis. So we're going wherever that call is, if out in the community, if it's a home, if it's just an address somewhere. Sometimes we meet people in an intersection. All we need is just kind of a direction, and we will be there to provide that support.
What type of safety preparation does your team actually do as they go out? Do they have dispatch levels, or how do they prepare for that interaction?
So we go in person to all of our dispatches. So that's very important to read that summary of our call. That summary will highlight if there's any weapons on scene, if there's a gate code, if there's pets in the home, if maybe that person would like a phone call once we arrive on scene and they would rather, for them to step out of the home versus us going up and knocking on the door. So we
Mhm.
do our very best to accommodate as well. Once we get on scene, if there's any concerns for our safety, we can always call for law enforcement. But the majority of our calls, we get dispatched on our own. And we just kind of work through some of those little challenges. Like I said, if it's dark and maybe we're unsure of the apartment number, because those are one of the main challenges for mobile. We can call. We have a phone number, and we say, we're outside your home. I just want to make sure this is the right place. Um, and then that can get you a good gauge of, okay, someone wants to talk to me. They'll typically turn on that porch light, or at least will come out, and they'll make us feel like, okay, it's safe for us to approach.
Okay. Thank you. And for us in Mobile Crisis in Georgia, we do something quite similar but we look at level and we dispatch at levels, which determines our safety in particular, looking at the location. Do they have weapons, pets? Do they have a history of aggression and violence as well? um, are they intoxicated, or is there some other risk factors connected to our approach and our team safety because of that? Showing up in our plain clothes and our own vehicles, in Georgia, we do not utilize vans. But I know, Kaitlyn, you guys do, you utilize vans as well, correct?
Yes, we do. So we have our company vans, and actually, something that we do with our vans is we have magnets that say that we're Aspire Mobile Crisis. So we actually always, when we are doing that preparation to go out on the run, we ask the individuals, do you want us to have identifying information on our van, or do you want that off so we can take the magnet off? Uh, Most people don't want the identifying information, that they feel a lot more comfortable with us going to their home. But we need to have it on there, because if we do co-respond with any first
Mm.
responders, or we ask them to co-respond with us, we wanted that there for the safety on that side of things.
Think you brought something up in the past that I thought was really interesting and important for everybody to hear. You guys changed the colors of your van.
Yes. So we started off with a white transit van, and very quickly got the feedback that it wasn't the most comfortable for us to go to homes. It's bigger, easier for people to look at it and see, like, that's not a typical van to pull up to this individual's home. So we now have black minivans that make it very easy to just blend in with the community, or wherever we're meeting them.
That's interesting. And how did you guys get all that feedback from clients you were going to see?
It was just within conversations with them. We always do follow-ups as well after our runs within the next 24 hours, but then ongoing. So it was just coming up naturally. And then also our first responder partners would were also noticing it, and like, I feel like maybe like that's not the most comfortable vehicle to show up on scene. So just got that feedback quickly and made the change.
That's super interesting. And I think safety becomes such an important factor in any type of mobile crisis response. What type of trainings do you guys provide for your staff, clinicians, and your who you like, what your teams are made up of? So maybe talk a little bit about some of the training and then the combination of who is on your teams.
So our teams is a two-person team. It's a BHT, so that could be a combination of education and experience. And then we also have a master level clinician on the team. And we also definitely want to have peers on our team. So if someone identifies as a peer, we embrace that because they bring a whole different level of support as well. And then all of our new hires do go to like new agency, new hire. And aside from that, we also have crisis training. So it's very specific to the crisis um,
Mhm.
position that they're going to be in. And it includes, safety in the field, how to use motivational interviewing, right? Because we only have possibly like 5 minutes as soon as you arrive, to build that rapport, to identify who you are, and hopefully gain that trust for that person to feel comfortable to talk to you. And then it's very consistent. So all of our new hires go through the very same process. Um, they also shadow a team, an actual mobile team, so they go out with them. So as a third, that way they're able to watch, and as the shadows progress, then they start, integrated into that position. Like they'll start taking the lead. Maybe they want to drive. They can use the phone, do the updates and the electronic health record. So by the time they're a second on the team, typically most people feel comfortable because it's no longer like new. They haven't done it. They have done it, and they feel confident.
So the teach, see, do approach of getting the people, not just throwing them out there into the field saying go.
Right,
Yeah,
right. And training comes in uh different types of training, right? There's classroom settings, there's shadows, there's kind of
right.
like you watch. So I think that's important too, because not all of us learn the same, in the same manner.
Yeah. Yeah.
I will say our trainings, pretty much everything was that Elizabeth was talking about was checkbox, all of
Mhm.
ours as well. Our mobile crisis team definitely has one of the most intensive trainings, because we
Mhm.
want to make sure that they are comfortable and know what to do in any situation they're walking into. We also do a lot of mock runs, just to practice. We do the same thing when you're newer. There's now 3 people on the team just so that new person can learn from it. We're starting a new thing because we have multiple shifts where we're having, when the next shift comes in, if they don't have a run immediately, they're going to review any of the runs that was on the shift before, just to help them understand, learn, make sure that they know resources that are available or maybe that were necessary. So really trying to do that in the moment training as much as we can. Our team, very similar, also 2 people. One has to be a peer, so we always have lived experience on our runs. And then our second is an individual who either has years of experience in the field or a bachelor's degree. So they are able to have that focus on the assessing and all those next steps. And then the peer, it can really focus on the rapport building and helping talk through those recommendations and what that might look like.
That's great. Yeah, our teams, we do incorporate peers. I think it's so important. In Georgia, we've really been pushing hiring our peers into our crisis teams, especially responding out. Sometimes they can engage with people a lot differently than people who've been in the field for years. So our certified peer specialists are very, very important to the crisis continuum and crisis care for sure. I wanted to kind of dive in a little bit as we're on scene and that engagement. We've built the rapport. I know in Georgia, we a lot of times have other professionals on scene or family members because we are, like you guys said, in the community, right? And we're engaging with all of those people who are in that community. And a lot of times, what we know is that engaging those family members and support personnel really, really help that individual in crisis be consistent, but also have a really good safety plan and connection to care. How do you guys and your teams teach people to engage with those other support systems and really gain their insight and influence into the crisis assessment?
Well, we're excited anytime we get to on scene and there's some supports we really want to embrace, right? That dynamic because it's fantastic if there is support, it's there. And if there's not, sometimes just within that conversation, like let's mobilize those supports if there are there, but maybe not present. So when we're having those conversations, we're asking, are they connected anywhere? You know, maybe they do have outpatient services or a therapist or a PCP. And maybe in the moment, the crisis episode, sometimes, people just forget about those things. But once you're having those conversations, sometimes you think, oh, okay, you do have a PCP. Okay, then let's note that, right? So as we move along our assessment, those are some of the pieces that will come together, right? Can we call if it's during business hours? And maybe if the concern is, medication or maybe some side effects, or maybe they're out of medication and, maybe that would resolve the issue. So definitely during business hours, we're calling. If it's after hours, then our mobile teams do coordinate with if they have a provider,
Hmm.
at least to just let them know we went out and that way someone can follow up with that person. We also have a follow-up team that calls just the very next day, kind of what it sounds like. And they can also assist if someone needs that help or that connection to outreach their clinic or again their therapist or any supports at all. And supports just general family members, neighbor, group home staff.
Hmm.
They're we want them in part of that intervention, part of that safety plan, because it's going to make our safety plan a lot stronger if we have someone that can, monitor, just be a listening ear sometimes.
Right.
So we definitely do try to do that.
That becomes so important for that continuity of care, and also too the family members and support personnel to understand what those triggers or those what that safety plan consists of. And I think that communication too, right, and the therapeutic intervention of modeling the connection of how to be open and trusting of your support and realistic support personnel who are around and how they can
Mhm.
reach out and connecting those people to them. Um, I wanted to just ask a really quick follow-up question too about if you do that follow-up call and there is still a crisis situation that's transpiring, do you guys go back out? How does that work?
We definitely do. So our goal really is one of our first follow-ups is to be able to be in person again. It's important to us to really help check in person. How are they doing? Have they been using the resources we were providing them? And we really feel like doing it in person helps give us a really good picture of what's going on.
Mhm.
Really interesting. Elizabeth, do you guys do in-person follow-up as well?
Yes, so we do on the phone, we could do a phone call, as a check-in. And then if someone is still not doing well or maybe just needs additional support, then we'll go out in person as well. So
Okay.
very similar.
Yeah, wonderful. And follow-up becomes so important in that aftercare and ongoing support for our communities and people in crisis, as well as the other support persons who are engaged and love that person too. So, thank you guys so very much for talking a little bit about what you guys do on a daily basis and giving some really fabulous insight into each one of the programs and how different they are. I mean, two completely different states and different geographical areas as well of our country. So I know there's a lot of other wonderful mobile crisis teams across the country, but really appreciate you guys and your insight and information. And I'm going to turn it back to,
Me.
yeah, today.
Megan to Megan, right?
Yes.
No, fantastic. What a wonderful discussion. Thank you so much to all of you for sharing your experiences. We're now going to do the roundtable and get some additional perspective. Let's go to Lori Nichols, who's the supervisor of the crisis team at Aspire and Indiana Health. Lori, welcome.
Good afternoon. Thank you for having me.
Mm. Would love to know your perspective and your experience as well in comparison and contrast for what they just shared.
Absolutely. So, Kaitlyn is my director, and so I'm going to piggyback on a little bit of what she shared with you, if that's okay. One of the conversations that I heard come up was safety when we're out with a client in the field. And so, one of the ways that our particular mobile crisis team communicates is we all have our work phones or our laptops. And generally, through our work phones, what we do is we always put in an ETA when we leave the office. We always put in an arrival time when we arrive with the client. And we also put in a face to face time when we arrive with the client as well. And then during that time, that we're out with the client, we communicate with each other via that personal that chat with our team or and our care coordinators as well. That way, one, we know that everyone is safe. We know what's going on at the scene, and then we can also be of assistance for additional resources that are needed as well. So, if we're looking for an intake that's still open at a certain time of day, if we need to help contact a provider, or if we need to do a transport, we're all able to communicate and get that information to our team that's out there in the field with our client as quickly as possible. Um, she did mention that we have our magnets that we did a change up on the vans, and we have our magnets that we can take on and off of our vans as needed. That's proven to be a big help in our community, as she stated. And we also wear our uniform T-shirts, and our T-shirts say "Mobile Crisis" on the front, and it's a little bit smaller. It's just a few inches, and we do that because one, we need to identify ourselves, in the community with like co-response and things of that nature. But we also don't want to wear a bright colored shirt with mobile crisis across the back of it because we do respect our clients and we do want to make sure that if they want us to kind of approach quietly and not let the neighbors or everyone else in the school know who we are, that we have that option to do so as well. Some of the things that we do as far as within our mobile crisis team, I personally am very grateful for this, and this is one of the reasons why I chose to work with Aspire's Mobile Crisis, is they care a great deal about our mental health as well. And one of the things that Kaitlyn and the rest of the team and the directors have implemented is that we have work from home mental health days. And so our schedule fluctuates on whether we're in the office, 3 or 4, 2 or 3 days a week, every other week. And so the days that we are not in office going out on runs actively, we're doing our caring contacts from home, which are like follow-up calls for those that just need a little bit extra care in between, like maybe therapy appointments or group appointments. We're able to reach out to them and see if we can assist them in any way. Just kind of check on and make sure they're doing okay. And then we also are able, if we need to speak to someone, if we need to kind of debrief from maybe a rough day the day before, when we walk into a situation that kind of maybe triggers a little bit of trauma for us, something that we've dealt with in our lives, or it was just a particular emotional day, we have that available to us as well. And so they are amazing at taking care of us as employees and as team members, as well as providing us all the tools that we need to go out and take care of our clients. Um, so big props for that.
Great.
And yeah, and then also we recently have partnered up with Navigate Hamilton County, and that is one of the counties that we serve here locally. And they have created a website within the county that anyone can go to. We're working on like the age. I'm not sure if it's just 18 and older or 18 and younger. There's a couple little things there they're working on, but they can go in and ask for assistance. So if it's not like immediate crisis where they feel like they need to call 988, but they're needing some help and some resources within the community, they can go in and fill that out on that website. And then some of us within the mobile crisis have signed up to be navigators, and we will reach out to them, call them, see what we can do to kind of help them with it, with those resources within the community as well. So those are just a few extra things outside of the day-to-day activities that we do on a mobile crisis run.
Love that, Lori. And you'll see in the chat just all the praises for so much of the approaches. And I know there are so many questions in the chat. So if any of the presenters today want to answer some in the chat, please go for it. They're just great questions. And there's even the suggestion to have another one of these so that we can get to some of those questions. So, and let's go to Thomas Latson, who is the mobile crisis lead for Behavioral Health Link. Thomas,
Hey, good afternoon. Can you hear me?
yes.
All right.
There you are. Fantastic. Thomas, what do you think? What are your thoughts?
Well, once again, I'm Thomas Latson. Megan Gleason is my director for Behavioral Health Link. Glad to be here. I say the work that we do is so rewarding, and I'm so blessed to be able to be a part of this. But I just wanted to talk a little bit about, some of the things that we value in our organization, right? So number one, immediate intervention and de-escalation, I think, is important, right? We have dispatch times or required times that we say that we're supposed to respond to these calls, right? We try our best to make sure we have immediate on the ground intervention, for any individual experiencing stress or distress in any way, right? We recognize that timely intervention can prevent situations from escalating. It can reduce harm, stabilize individuals, right? So they can have access to appropriate care. Another value we have at BHL is reducing emergency room and law enforcement involvement, right? That's one of the main things that are important to us. We feel that, traditional responses to behavioral crisis, they often involve emergency departments, law enforcement. Crisis teams offer an alternative that reduces strain on hospitals, and it minimizes the risk of unnecessary arrest and hospitalizations. We also emphasize community safety and public health. We feel that effective crisis intervention enhance community safety, by ensuring individuals receive proper care, and also, proper care instead of punitive responses, as often, they experience, right? So we think it's really, really important that we reduce and minimize the risk of unnecessary arrests and hospitalizations, right? Um, Community safety and public health. So effective crisis intervention, we enhance community safety by ensuring that individuals receive proper care instead of punitive responses, like I said, and it reduces the risk of self-harm, suicide, and harm to others, right? Also at BHL, we think we value support for families and caregivers, not just for the individuals. right? So crisis response not only support the individuals, but we also provide resources for the family and caregivers, just in case, after a follow-up, let's say an individual is 1013 or sent to some sort of inpatient facility. We always make sure we provide resources for those supportive people, right, to be able to help that person when they're back home. And then finally, one of the other values that we have is the linkage to ongoing care, right? Right, crisis work ensures that individuals are connected to appropriate follow-up care, such as outpatient therapy, medication management, community support services. We do believe that promoting this continuity of care reduces recidivism in the community. So these are important values that I feel that our organization, tries to home in on, with every dispatch.
Thomas, that is amazing. What a kind of a wraparound feeling that an individual might feel from everything you're describing, and the support of the mobile crisis responders. One thing I really want to note, just an observation, is Thomas, your hopeful attitude, your energy, and the energy and hopeful attitude of all the presenters today. Wow. Like that tells me that you all feel that sense of purpose, that what you're doing, it makes a difference. And so that is just wonderful. Thank you for the wonderful work you all do. Yeah. Thank you. And let's shift to the NASHBID update. We have Matthew Perriott, who is with the Tennessee Department of Mental Health and Substance Abuse Services, and is the communications director. Matthew, I'm going to turn it over to you to talk about Promise to Call.
Hey, everybody. Happy, what is today? Wednesday. Happy Wednesday from Tennessee. I'm staring down the barrel of a beach vacation, so my days are getting a little mixed up here. Very, very excited to be joining this call and so excited to hear about all the work that's going on across the state. Just this energy as a communications professional is just, it's palpable. So it's always fun to get to tell stories and be around folks who are doing amazing work like this. So Promise to Call is something that is really cool and really different that we have launched relatively recently in the suicide prevention space. There's so much great work going on in Tennessee and states all across the nation, at the national level, at the local level, at every level. There's a lot of great suicide prevention work going on out there. But my commissioner, of course, as we all see, we're still losing too many people to suicide, right? So she kind of had this kernel of an idea, lightning bolt inspiration to make this into a campaign to supplement the work that's already going on in the suicide prevention space. So the concept is you are making a promise to yourself right now, right today. You could do it right now, literally. You're making a promise to yourself that if you ever have those thoughts that you're going to take your life, you're going to call somebody, you're going to text somebody, you're going to reach out because your life is worth that. And so you're making a promise to yourself. And the thing that is so universally appealing about this program is everybody knows what a promise is, right? I've got a 7-year-old, a 5-year-old, and now a 2-year-old. If you can't see the Minnie Mouse balloon up there, she just had a birthday. They know what a promise is, right? And it's something that when you make a promise, you're going to remember it. If someone makes a promise to you, you're going to hold them accountable. There's a lot writing on that, right? And so we're asking with the promise to call, promise that you're going to call and talk to somebody. Write it down, make a contact on your phone. It could be anybody. It could be your Uncle Bob. It could be your pastor. It could be your favorite teacher from high school. It could be 988, right? It doesn't have to be a specific person. It could be 988. That's a perfect way to do it. And so the idea is, you save it in your phone. I've got little business card of all the printed material handouts that we have. We've got tens of thousands of little business cards, and on the front is what you see here. promise to call, promise to listen, promise to learn, right? And then on the back is a spot for you to actually write it down and to keep it in your wallet, to keep it in your purse, to keep it on you. If you're like my mom and you have one of those cell phone things that organizes everything all together, right? So it's just that simple. It's just that simple. You're making a promise to yourself, and then you're promising to learn about the other resources, and you're promising to listen if somebody reaches out to you in a time of need, right? That's the other thing. We want to start a conversation around saving lives and what that takes, and the hope is, normalize having the conversation, right? So you see the website right there, promisetocall.com. You can go to it right now. We have a video PSA, which we're running on a campaign right now. Really, really proud of that. It features people who have personally been touched by suicide loss, people who work at crisis centers, people who work in for my department. So a lot of really great faces helping to spread that message. But just so excited to share about that. Promisetocall.com, and I'll drop a link in the chat as well. We have a partner toolkit on a Google Drive, which, if you're interested in learning more, want to dive in, that sort of thing, it's there for you to explore. So thanks for letting me share.
Great, Matthew, that is awesome. And what great work on Tennessee. And Commissioner Williams is just, she's like, let's go do it, right? Fantastic. Let's thank you so much for being here today. Let's go to Emily Feltrin to give us the federal update. Emily is with the American Foundation for Suicide Prevention. Go ahead, Emily.
Thanks, Megan. Great to see everybody today. Always enjoy the opportunity to hear from others and kind of talk a little bit about what's happening in DC. So since we last checked in, the budget request from the Health and Human Services, based on what the administration is seeking for the upcoming fiscal year starting October 1st, that's fiscal year 2026, that was made public. So this includes both what's called the HHS budget in brief, as well as the proposal for the new administration for a healthy America, which we've talked a little bit about in the past, which would include SAMHSA, HRSA, other agencies within a new structure within HHS. So these levels that came out, just to note, these are proposed. It is up to Congress to decide on the final funding levels. And I'll include a couple links in the chat based on what those levels are, so everybody can take a look if you haven't seen those as well. But just to flag, the proposed budget includes $520 million for 988. This stays at the same funding level as the fiscal year 2024 and 2025. It does also, as we had been expecting it might, based on the leaked passback that came out earlier, include the elimination of LGBTQ plus youth specialized services. And just to note that those specialized services have received nearly 1.3 million contacts from youth and young adults identifying as LGBTQI plus since it was started. So again, next steps are up to Congress. Congress will draft appropriations bills and then ultimately decide on the final funding levels for these programs. So stay tuned. Contact your members of Congress if these issues matter to you. And then reconciliation. So when we talked a couple of weeks ago, the House of Representatives has passed its reconciliation bill, and it did include cuts to Medicaid, which, just to note, is the single largest payer for mental health services in the US. Now, this week, Congress is in session. The Senate is actively working on their version of the Senate reconciliation bill. And for those who are newer to this conversation, just a reminder, reconciliation is the process that Congress uses to move quickly on certain types of fiscal bills, so tax, spending, debt limit, legislation, and this includes Medicaid and Medicare. So next steps, Senator John Thune says the bill will most likely come to the floor in the next few weeks before the July 4th holiday, but as with everything in Congress, everything is dynamic, things could shift. So more to come, and we'll be closely tracking that. And on a final note, just wanted to share some additional good news. The House has passed the 988 Lifeline Cybersecurity Responsibility Act as part of the larger Support Act package. And this would strengthen the security and reliability of 988. It was co-sponsored, bipartisan by Congressman Jay Obernolte and Congresswoman Debbie Dingell. And it now moves on to the Senate for that next step in consideration and hopefully passage. So thanks, Megan. That's all for today.
Great. Thanks so much, Emily. Really appreciate your work. And let's go to Dr. Tina Soma for the Tech Corner.
Thank you so much, Megan. I'm Tina. I'm from a company called Listen. I'm a research scientist and clinical implementation consultant. Today, I'm going to talk about a foundational study that was put out by Fitzpatrick and colleagues in 2017, which right now feels like about a million years ago with how fast chatbots, AI technology is moving forward. But I think important for us to think a little bit back to our roots of where some of these foundational studies were happening. This study has been cited nearly 2,500 times in articles, reviews that are coming out between 2024 and 2025. So what this study did, again, this was an early version of Wobot, which is a rule-based conversational bot. They did one of the first randomized clinical trials with a type of conversational chatbot in a 2-week treatment group or two-week treatment trial. They looked at a non-clinical population of college students and they compared that population to what we call a waitlist control intent to treat group or an informational control condition that's very standard in randomized control trials. Again, I'm just sort of noting it is a non-clinical college population, so we can make a limited amount of inferences from their conclusions that they drew. The next talk is going to go a lot further into different types of generative AI, rule-based AI, and all types of things for bots. So again, this is a rule-based, decision tree-based AI bot. This is not a generative AI bot in the 2017 study. Their effects that they found on the GAD-7, so looking at anxiety scores, was a small to moderate reduction in anxiety with a Cohen's d of 0.37. They also saw reductions in PHQ-9. The parts of this bot that were included in the tests in the particular clinical trial was around psychoeducation, empathic responses, how to tailor different types of interventions to the individual, goal setting, accountability, motivation, engagement, and reflection. And this is something that we see in a lot of different types of conversational chatbots right now. And David, I'll have you go to the last slide. Again, this study was performed in 2017. Since then, we have seen an exponential amount of randomized clinical trials, peer-reviewed studies, systematic reviews, qualitative reviews of all the different types of chatbots and conversational agents that are coming out right now. Again, this is very exciting. And there are a lot of different types of bots that are coming out. Again, the next talk is going to discuss generative AI versus classification AI versus judgment or decision tree based AI. Not all AI is the same. Some of these bots are more embodied conversational agents that are more free flowing. Some are socially assistive. Some are chatbots. Some are for health promotion, education. Some are specifically for elderly support and dementia and cognitive impairment, supporting folks going through different cognitive changes, going through and needing different types of health support, neurocognitive, developmental disorders. I could go on for a long time. There are a lot of different types of bots that are coming out. They serve a lot of different types of purposes. I want us and encourage our community to continue to examine the appropriateness of the different types of applications that are coming out. I hope that we can ground ourselves too in studies that were done in the 2017, 2018, 2019. How have we grown and changed from there? What are the red and pink flags that are coming up for new bots coming out? What does the science look like? And again, the last question that I'll end on before turning it over to our next speakers, I want us to ask ourselves not necessarily how AI can solve a problem, but first, should AI be the thing that we're using to solve a problem? If that problem feels appropriate, if the content feels appropriate, if the types of tools and development is available, then what type of AI am I using? Has it been sourced responsibly? What is the research that's backing it? But let's first ask that question, should AI be the thing to solve this problem, and then move forward from there? Thanks so much, Megan.
Thank you so much, Dr. Soma. I really appreciate your work on this. I mean, being cited 2,500 times is incredible. So thank you. And let's go to Stephanie Hepburn to do the crisis talk. Stephanie.
Thanks, Megan. So that segment was a great transition into this segment. I love what Dr. Soma is talking about. And that's like a great segue for me to bring on Nicholas Jacobson. He's a clinical psychologist and associate professor of biomedical data science, psychiatry, and computer science at Dartmouth. And he spearheaded the first generative AI digital therapeutic chatbot. And one of the things that he and I discussed was what's the difference between rule-based versus generative AI? And I wanted to see if you could break that down for our audience.
Yeah, I think it's actually a fairly big distinction. Thanks for the question. Prior systems in the past about 15 years have really been using rule-based chatbots in mental health. And this actually starts with the origins going back to the 60s, actually, of these systems taking place. The difference between a rule-based chatbot and generative chatbot is in a rule-based system, everything is pre-written by the system content creators. So folks are writing out what the bot will say in a rule-based system. And a lot of the conversational flows within these systems is predominantly a bunch of if-then statements that can allow for different navigations and routing. I'm sure everyone on this call has actually interacted with a rule-based chatbot or a rule-based conversational agent. These are very popular in customer service settings. So really, when you would be calling your internet service provider and things like this, a lot of the routing options are often powered through that fundamental technology where the authors have to design and intend exactly what the bot will say. The difference between that and generative AI is generative AI is actually producing new potential text or speech that is based on essentially trying to predict the next token that is most appropriate based on its training data. So it's if you've interacted with ChatGPT or you've interacted with other generative AI-based technologies, those are example technologies there. Very different in form in terms of the types of responses you get. Because of this, the upside for what it can deliver empirically and therapeutically is far greater, I think, in large part, but the risks are also far greater.
And that's one thing, transitioning to the next question, that was one thing that was so different. I tested out, many of the commonly broad use AIs, not only the AI assistants, but also the AI companions, like character AI, for example. And then on the AI assistant, I looked at ChatGPT, Claude, and a few others, and you can see that in the article, but there were huge differences, inconsistencies. And interestingly, I tested this out also in April, and even since April, there were some differences between what ChatGPT and Claude were doing versus the others. For example, ChatGPT and Claude actually now provide a follow-up question when you use language that indicates you might be experiencing suicidal ideation. That's a little bit of a pivot, a little bit of a shift to keep that to encourage that dialogue to keep going, not only provide resources, but with Therabot, it's much more robust. There are 3 layers of a safety net, internal guardrails. Can you talk about what those 3 elements are and why it matters to keep the conversation going?
Yeah, I think there's I think several elements of this. So the first is that we have a risk detection module that we have to try to flag actually any kind of crisis intervention content that is being expressed by the user. That will do a couple of things. One is that it will have a crisis button that starts to flash when folks click on that, and it's pretty apparent when folks would be interacting with the application as to something has changed. The folks would then be able to direct it to really crisis services there. So ability to directly call 911 if it's an acute crisis, but also contact 988, and then also through call or text. In terms of the ability, on top of that, we have humans that are part of the team. So they evaluate every message that is sent to or from the bot. And we also will then engage with folks related to these types of things. So part of the humans that are part of the system, it also brings a flag for us. And so it allows us to act on this. We're going to be in these trials reading these messages, regardless of whether the flag actually gets raised, but it certainly makes us look at it first among the priority queue. I think the bigger thing, I guess, in terms of the behavior is our system was designed to actually deliver crisis intervention, which is very different from every other system that you're going to probably interact with, in large part because they're trained based on the entirety of the internet. And they're the guardrail surrounding the technology is really rule-based inputs that folks are using through prompts to try to often evaluate these systems. So in large part, we are trying to deliver evidence-based crisis support in those times by not withholding care and allowing the conversations to continue. We thought a lot about why we wanted to do this, but a lot of why we are trying to do this if folks are actually interacting with the chatbot, that they don't actually say they're not willing to engage in other services or resources. They don't pick up our calls, for example. We'd rather them have support than withhold it.
Thank you. Thank you so much. I'll pass it back to you, Megan.
Thank you so much, Stephanie and Nicholas. Really appreciate it. And, thank you everybody for joining us today. Just a reminder that next week is the debate on crisis facilities, on whether crisis facilities should require parents to stay during a crisis episode. So hope you'll join us for that. And then the week after that, there's a feature presentation on North Carolina's 988 and Pure Warm Line integration. So super thrilled about what's coming. Great stuff. Thanks everybody for watching today, and have a great rest of your week.